Welcome to the Pedantic Zebra Book Club podcast, a quarterly intersectional book club exploring chronic illness, disability, medical history and crip culture, hosted by Long COVID Advocacy. Everyone is welcome to our listen, read along sessions at 8 p.m. UK time on Friday night. You can follow along on Goodreads and social media using the Pedantic Zebra hashtag.
Hello and welcome to this second episode of the Pedantic Zebra Book Club podcast. This episode, I'm interviewing Dr Rageshri Dhairyawan, author of Unheard, the Medical Practice of Silencing. She's a researcher and NHS consultant in sexual health and HIV medicine based in London. Her clinical work, research, writing and advocacy focus on improving health equity, and which is a subject close to our hearts, and we're delighted that she can join us tonight. Let me quickly show you the book, proof that we've read it, and I'm sure you have too. And that's what we'll be focusing on. So, without further ado, let us bring in Dr. Dhairyawan.
Hi there.
Dr. Dhairyawan, how are you doing?
Good, thank you. Really nice to see you, Rupert. It's a real delight to be here, and I'm so honoured that you guys have chosen Unheard to be part of your book club and that you wanted to have a conversation as well. So, thanks so much.
Oh, well, that's absolutely our pleasure. And welcome to the podcast. So can I just start by saying, just as someone who has to write a little bit for a living myself, your book was just meticulously written. It was really, really clear, so well researched, so sort of really balanced and even-handed and careful in its tone and argument, and a real pleasure to read. So before we get into the sort of the detail, just how do you feel about it as an author, having got through and got it out there?
That's a really good question. I think, it's been out almost a year now. And I think this time last year, I was so nervous because, you have no idea how people are going to find it. And because the book is meant to be for everyone, I wondered how different audiences would find it. So you'd be that medics, patients, general public. So I think a year on, I feel quite proud of it, to be honest. It's my first book. I took a long time writing it and thinking about it, and I think people have understood what I've been trying to get out there, and just the interest I've had from different groups has been really encouraging. So yeah, I think I feel proud of it, but I actually quite miss now the writing process, so maybe time to think about number 2.
I bet. So I'm sure it's delightful to get back into practice, but it must be a real break and just a different view on the world, and something that you must have come to appreciate in the process.
Yeah, absolutely. And I think, I wrote most of the book while I was still at work. I wrote it in my annual leave. So it gave me this really lovely thing of going to work, doing my day job and then thinking about it and then writing about it. So I had like an avenue to really reflect, which I don't have so much now.
Great. So for anyone who hasn't yet read the book, and though I think many on here tonight will have, can you briefly outline what you mean by silencing in medicine and why you were moved to research this and to write a book on it?
Yeah, so for me, it's really thinking about who in healthcare doesn't get listened to, who doesn't get believed, and how when it happens repeatedly to them, it means that they stop talking and they self-censor and they become silenced. And it was really important to me in the book to think about this in different levels. So to think about who it affects. So be that patients, be that minoritized healthcare workers or researchers, be that global communities in the global south, for example, and also really think about silencing at kind of individual levels, systematic and institutional levels as well. And for me, there were 3 reasons why I wrote the book. So apologies, I'm going to go through all three. So I guess the first was an incident I had as a patient now about 12 years ago, when in the middle of IVF treatment, because I have endometriosis. I had to have IVF. I developed very severe abdominal pain after my eggs were collected, and I was admitted to hospital. And the worry was that I had a surgical emergency. And luckily I didn't need surgery, but certainly the hormones from the IVF had exacerbated my endometriosis. And when I was on the ward, I didn't get the pain relief that I required. And I was just very struck at the time how I didn't feel able to speak up for myself or to complain. I had to rely on my husband to really advocate for me. And when I left hospital, again, I didn't complain because I just wanted to forget about it. And I just felt very guilty for a long time afterwards, thinking, if this could happen to me, if I could be silenced as at that point, a new NHS consultant, someone who speaks English, someone who really understands how health systems work, what happens to everyone else. So I think the main thing it really taught me was that, we always tell patients to speak up or to shout for better care, but it's very hard to do that when you're at your most vulnerable. And, we in healthcare need to listen better. So that's the first reason, was really reflecting on my experience of being silenced and not wanting it to happen to other people. The second is, I work in sexual health and HIV in East London, and my patients are often from very marginalised communities, quite, very stigmatised illness. And I think, these are people who we don't see in government policy. They don't get money, or they don't get that real focus that you see with other conditions. And again, I think, it's not that they're not trying to speak up, it's that they are silenced. No one is listening to them. And thirdly, I've been a doctor for 20 years now, and I wish I could say that, every single time I've listened to the best of my ability with every single patient. And I think, even with my best intentions, I haven't always done that. And I really wanted to explore why I couldn't always listen well from the other side as well as the doctor. So that's my very long explanation of why I wrote the book. But, the real three things for me about being a patient, highlighting patients like mine, and being a doctor.
Great. Well, I'd say it was only moderately long, but really clear. And I think, as you saying at the start of your book, this is something that starts early, in the process of creating new doctors, and with medical school and medical training itself. And so you write about how silencing starts in medical school. Could you say a little bit more about it, and perhaps then what sort of changes of approach and of practice might be required in medical school to mitigate against that at an early stage?
Yes, I think ironically, medical students are quite good listeners. I think they're generally quite interested in who they meet, and they kind of want to hear everything. And then we teach them how to communicate with patients, and to take histories. And we teach them to do that in a really selective way. So, we're trained in Western medicine in the biomedical model of medicine, which is really thinking about bodies as being like machines, and diseases being separate from those bodies. So we take that kind of human aspect out of medicine quite early on. And when we take a history, we want to hear certain things that we think are important to the diagnosis and to treatment, but that's not always everything that the patient wants to say. And sometimes, we miss actually really crucial information that is helpful for diagnosis and for treatment and for making decisions together. So I think, we teach our students this very selective medical history taking, which can be useful because it can save time and we have to learn to be efficient. But, it misses out some of that real human aspect of patient care. And I think the other thing that, that we do is that we, medical students are treated as being special. And I can remember feeling that special feeling when I was at university 25 years ago. We are treated as the most hardworking. We're going to do something very important with our lives. We are going to save lives in the future. So that, plus we had the longest hours out of all of our student colleagues. We were very much kept together as a group, and we were treated as if we were special, and we treated each other as if we were special. And I think that's really important when you think about power in medicine and those kind of hierarchies. We're kind of taught and treated as if we're at the top of the power hierarchy and everyone else is at the bottom. So, one of the things I think that would really improve is that, as at medical school, if we had sessions with other healthcare workers from different disciplines, so say nurses, psychologists, people who have different expertise to ours, but, so we can meet them, learn to value their expertise, and hopefully take some of that real hierarchy out of medicine as we go into practice. And also, we just need to see patients earlier on. Patients need to be involved in curriculum right from the start. We need to see them from year one. So I think all those things would really help us teach medical students to listen better and to really challenge those power imbalances and hierarchies.
Thank you. And I think I can't resist jumping in there, just thinking about how in your book you talk about the fact that you got the chance to take a break, to step back and read, and to actually read, some philosophy and history and those the arts and social sciences, and I guess, do you think that those brought in different types of thinking that perhaps aren't encouraged so much in sort of, especially for people who might taken straight sciences all the way through. What sort of how is an education and in those wider sciences and arts affected your thinking about medicine?
I think hugely. At medical school, we had the option to take some special study modules. I think it was like 1 or 2 a year. So you get to choose to do something which might be very related to, might be very medical, or it may not be. And I remember maybe in my third year choosing to do the history of medicine for a term, and my project was on the history of pregnancy in Western medicine. And I didn't know really anything about it, and I certainly didn't know about the concept that medicine could be sexist. So to really read about all these experiences of women over the years and how they're treated during childbirth was really eye-opening for me. And I think that has really helped as I've gained an interest in health inequalities in my career to really think about how those real social factors affect people's health and outcomes and experiences of healthcare. And, I wouldn't have got that if I hadn't chosen to do that. And unfortunately, medical humanities are optional at the moment. So you have to choose to do it. But I think if there's a way, it could be kind of more ingrained in the curriculum, if there is room. I think it's good for us to kind of understand the more human side of medicine, the art side of medicine. It's not just a science, but it's also been shown to be good in terms of things like preventing burnout amongst doctors. And I think that's really important when it comes to get us listening better. We need doctors who aren't burnt out, because you certainly can't listen if you are.
Yeah, and I think from the other side, actually, the sort of history and for historians, philosophers, and the like, they're often fascinated by looking at the history of philosophy of medicine. It provides a huge insight for them into their thinking. So, but you mentioned sexism in medicine, and you also wrote in your book about how the only significant ways in which women's health is covered in medical school, or was at least relate to childbirth and cancer. What do you see as the most important issues that are overlooked as a result? And again, where do we start?
Well, that's such a big question, actually. So I think I was referring to what's termed bikini medicine, which is we only really think about women's bodies on those bikini bits. So things to do with the breasts, things to do with the sexual and reproductive system, and obviously pregnancy. And I think, obviously women have other organs as well. We have the same organs as men. We have other parts of our body which are just as important. But there's been a real historical lack of thought and research into women's bodies, and this has mainly been, related to the fact that in the history of medicine, physicians have been mostly men until relatively recently, and they have, there's a real written history of how women's concerns have been dismissed over millennia. Painful periods were first described 4,000 years ago, but they weren't really taken seriously until very recently. So there's that history of kind of the dismissal of women's concerns, which has led to a real lack of research interest, policy focus, and means that we have these knowledge gaps about women's bodies, which need to be filled. And in the book, I use the example of endometriosis, which is a bikini issue because it's to do with the reproductive system. But there's so much we don't know about it, and yet it affects 1 in 10 women of reproductive age around the world. So ridiculously common, yet we don't really know how to diagnose it without surgery or treat it. So I think things are changing. I think that's been because of we now have more female physicians in more leadership positions who are perhaps taking women's issues more seriously. We have more researchers now. There's more funding being done. But I think it is important to consider that, when we're doing research trials on issues that affect men and women, for example, we need to include more women in those research trials. So if it's a drug trial, for example, although, women's bodies aren't massively different to men's, it's important to know, will they have the same side effects? Is the dose the same? So I think, we need more research into women's health generally, but we need it into things that are outside of the bikini zone as well.
Absolutely. And, and you say, women's bodies are not that different to men's in most ways, but there are undoubtedly probably ways in which they are different that we don't fully yet understand as well. And as we, we'll come on to the topic more of chronic conditions and how more women suffer from them from men a bit later on. But there's a whole, we don't know what we don't know in that area as well, don't we? And where there hasn't been research, we're not likely to know. Yeah. So one striking concept that you explore in the book, and before we started the live stream, I said it's one of those sort of eureka moments where the phrase itself almost explains itself. But you talk about disease prestige. So can you tell us more about what that term means and how you use it? And can you also tell us how it relates to those with chronic or less easily treatable conditions?
Yeah, so disease prestige is a concept that I hadn't heard about until I started researching the book. But when I heard about it, it made complete sense to me, and also to to other medics that I've talked about it with. So it was coined by some Norwegian researchers who were doing some research, and they noticed that doctors had implicit judgments about patients which depended on what kind of disease they had, and that there seemed to be a hierarchy about how they judge the patients and those diseases. So they did some really interesting research. They basically surveyed Norwegian doctors and medical students, and they gave them a list of 30 conditions and asked them to rank them on how important they thought other physicians would rank them. And I think what's really fascinating about this survey is they did it 3 times over a 30-year period, and they found the results were pretty much the same, apart from one notable difference over those 30 years. So those conditions which they thought were the most prestigious were things like brain tumours, things like heart attacks, and things that they found least prestigious were things like anxiety, depression, and fibromyalgia, which, as you know, is a chronic condition where there's a lot of pain in the body and fatigue. There was so they looked at these results and they thought, this is very interesting that this hasn't changed in those 30 years. And they concluded, there's probably 3 factors that really decides a disease's prestige. So one, it's the type of disease. So is it something that is, something that develops suddenly, is life-threatening, something that's very easy to diagnose because there's tests and very obvious diagnostic signs. So it has that kind of objective side to diagnosis. So those are deemed to be very kind of prestigious diseases, whereas those less prestigious are those that are chronic, where there are few objective signs or diagnostic criteria. So we have to rely on patient testimony to make the diagnosis. Also, conditions thought to be self-inflicted, like alcohol liver disease, and things not to be associated with a specific organ. So conditions that can affect the whole body. As well as the type of disease, they thought prestige depends on the type of patient. So more prestigious diseases were ones that affected patients that were younger, more likely to recover, and to recover without any long-term complications. And finally, the type of treatment. So more prestigious diseases had kind of exciting treatment, possibly high-tech, life-threatening treatment, but which you could cure someone. So they thought patients with these kind of diseases, these were more prestigious. And I think it is important because we think about how doctors treat patients with those conditions. If you have a low prestige condition, your doctor may not take you so seriously. You may find yourself more likely to be silenced. And, in the research, they did talk about fibromyalgia. I think, when we think about other conditions like long COVID, where there are few diagnostic criteria that aren't from patient testimony, for example, so we don't have a one test that we can do. Doctors are often uncomfortable talking about those kind of conditions where they can't just diagnose something with a test, and we don't have a clear treatment to make people better. So these are, I think, particularly for long COVID, for ME/CFS, these are examples of low prestige conditions which doctors don't like to treat as much. So that's why I wanted to put it in the book, because I thought it was such an important concept. And, when you're a medical student, you can tell, you want to go and see a patient who's having a heart attack who's going to be cured with this amazing treatment, because that's exciting and you're saving lives. It's very different to being in a GP surgery where you're seeing someone who's with a chronic condition and maybe the doctor can't do something as simple and amazing, seem to be as amazing as curing a heart attack. So I think it comes in right from the start.
That's really interesting, and it's brought up it's made a few connections for me that I will indulge myself with by sharing. You asked me not to go too much into the philosophy, but I can't resist just one term that a French colleague of mine actually taught me many years ago. I hadn't heard about it when we actually wrote something on soteriology, which is saving. an idea of trying to save people or things. And it seems to me that what you're describing with disease prestige is where you have the possibility of medical interventions that make it feel like the doctor is saving the patient, performing one dramatic gesture that saves their lives. And so that it firstly reflects well on them instantly as doing the curing. And of course, for that to work, the patient or object has to be demonstrably worth saving and of high value in themselves. And so I wonder if that idea of soteriology so it comes into it to agree. So it seems interesting to me.
And certainly see that people would like to put on their capes and make people better, and I can see how that would come in, that saviour view.
Yeah, and I guess the other way in which that might be relevant would be the difference between curing and caring, where being shown to actually make the transformation is high prestige, but when it comes to helping look after and improve and perhaps modestly improve the situation over time of someone who is struggling, but without some miraculous change, then that also that would also matter. And then, of course, that probably reflects on the gender angle that you mentioned in the book as well, because as far as I think I'm right in saying that you mentioned with respect to surgeons, for example, you've still got the biggest gender gap, haven't you, between men and women? And so perhaps, do you think it reflects also on, there's a sexism inherent in who gets to take those saviour roles?
Yeah, I think so. I think, the medical profession is traditionally male. So, who gets, there's a lot of bias against women, particularly in those, in those specialties where you have to use your hands, or it's deemed to be very high tech, and maybe, women's brains can't quite deal with that high tech nature, or we don't have the precision, or, I think some types of surgery are seen as being, very heavy and physically women can't deal with it. We can't stand for long hours in theatres, which is obviously rubbish. But I think that is part of it. I just wanted to come back to one thing about the disease prestige thing, because I said there was one notable exception in that 30-year survey, and I think it'd be good to discuss it. So the one disease that changed from low prestige to high prestige in 30 years was strokes, which are often caused by blood clots leading to blockage of brain, lack of oxygen to the brain. And for years, certainly when I was a junior doctor, when someone had a stroke, there wasn't much that we could do for them. You kind of have to see what happens, see what brain damage people have. And people used to stay in hospital for a very long time, and hopefully they would regain some kind of neurological function. But then that massively changed in the last 15 years, where, imaging has changed so we can see what's happening better. We now have clot-busting medication, which means that we can treat strokes as long as you get the clot-busting medication within a certain time frame. So there is now, an on-call stroke rota. We have big public health campaigns which say if you see these symptoms in your loved one, go to hospital now. So it's suddenly got very exciting and blue light. And it has meant that we have much better outcomes for strokes, actually, this change. So stroke has suddenly become more exciting and has become more prestigious. And I think it's very interesting to see the change in our diagnostics and treatment has really changed its prestige level.
That's so interesting. Thank you. Yeah, it's found its cape and it's flashing blue light, and I like that idea. So yes, and so up goes the prestige. So in your book, you make a powerful case for doctors to learn to really listen and empathize. You say that they're naturally inclined to do so, but there are some barriers that get in the way. But to really listen and empathize with patients, both on humane grounds and because it's likely to promote better outcomes for care as well. Do you want to just say a little bit more about that?
Yeah, I think we can often think of medicine as being just very scientific. It's very technical. We ask you the questions, you tell us the answers, we do the right tests, you get a diagnosis, you get treated. And for lots of conditions, that's great. If you have broken your leg, you want to have surgery, you want to get it fixed, and that's absolutely the right thing to do. I think, sometimes we can be busy and stressed, and it can take some of our ability to be humane out of our consultations, obviously depending on the specialty and what conditions we deal with. So I think being able to listen well, to really hear what the patient wants out of the consultation is important. So GPs are taught to do that. They're told to try and elicit what the patient's concerns are and what they want out of the consultation. So I think that's something that we're taught to do, and I thought that it can be helpful. But I think I'm also aware that patients want doctors who can make them better, not just people who can make them feel better because we're being nice to them.
Thank you. Yeah, and that does sort of bring me on to the second part of my question, which I think is particularly pertinent for people with chronic conditions and with long COVID and ME particularly, which is the thought that there might be a potential sort of shadow side to doctor empathy, if you like. Have you encountered situations where doctors might, unconsciously or not, sort of use empathy, saying, this must be so hard for you, or you must be feeling so anxious, almost like as a shield against really listening and learning about their needs?
I haven't seen it, and I haven't heard it being explicitly addressed. And I think that's probably something, so it's really interesting for me to hear it from the patient side, that this is something that happens. And I suspect these are doctors who are probably trying to be well-meaning. I don't know if that's an intentional shield. I can't say, but they're probably trying to show, empathy because they can't do anything else, and they feel, I'm not sure what to do to help you. So at least if I am showing empathy, this might make you feel a bit better. It makes me feel better. And perhaps they may not recognize that they are stopping people from speaking and they are silencing them. So that's one of the things I say in the book, is that we can silence patients without even noticing it or meaning to. And I think that's an important thing for us to realize that we do. So I wonder if that kind of toxic empathy is one of those ways in which we think we're trying to help, but it's really not helping.
Thanks for that. And that reminds me of such a powerful scene near the beginning of your book, when you're talking about an HIV patient who isn't taking their medication and who absolutely insists to the doctor that they are. And the doctor can tell from the blood test that they're not, what is well disposed towards the patient, and simply cannot understand why they're lying to them about it. And you go on to explain that it's their previous encounters, in part, that have left them so separated and isolated from where they haven't been heard in the past, that even that well-meaning doctor at the time can't cut through. But I think this issue also talks one that we spoke about previously too, which is perhaps this phenomenon of almost sort of unintentional gaslighting that can happen, of providing empathy where there is perhaps a lack of understanding, is because doctors might struggle to recognize, they don't have the training or aren't used to saying, I don't know, this isn't something that I fully understand, or this isn't something that I can help you with. And I wonder how that might, if that's something that I think it's something you must have encountered in your own work, especially before some treatments became available. So I wonder what your thoughts are about that, about doctors' propensity or willingness to show the limits of their knowledge.
I think that's a really good question. And, I certainly can't remember having this being discussed when I was at medical school, or being prepared for the fact that I may not be able to help patients. And I think most healthcare workers go into the profession because they do want to help people. I think it's, there is there is an element of, we want to help people, we want to fix people. And then you get into medical practice and you realize you can't fix everyone. And I think there's a statistic I used in the book. I think it's something like 30% of people who go to their GPs with symptoms, their symptoms are medically unexplained. So actually, we do see quite a large proportion of people with symptoms that we don't really understand. And for many of them, it will be something that's transient, it gets better and goes away. For other people, it may be something more chronic, but we don't know because we don't have the research to really understand what's going on yet. So I think as doctors, we want to fix people. When we can't, we get very uncomfortable with that. I think that's often when we shut people down and silence them because we don't want to hear more about stuff that we can't help with. I think this thing about uncertainty and being honest. I think it starts off with being honest with ourselves. I think that's the first step, is that really understanding that we don't know what's happening at the moment. And I think then the next step is for us to be honest with our patients and also say that. But I think we get scared in those scenarios, and I think we can get very defensive, which probably comes across in not a very nice way to the patient. So I think it is something that is being taught in medical schools now, actually, dealing with uncertainty, which I've certainly is a new thing, which I think is excellent, to have us more prepared to be honest with ourselves and to our patients. I think is really important. And again, as you say, there is research that says that patients want their doctors to be honest with them. We don't want to be given false hope, and I think that's really important.
Thanks so much. I want to sort of follow that a little bit, if I can, but I know I'm very aware that the sort of the field that I'm talking about with chronic illness and it isn't your field. I realise that you don't want to sort of lecture on topics where you're not the expert when there's so much that you are. But I thought I might do this question in a slightly different way. So the lived experience of people, especially those with severe long COVID and ME, is that the desperate seriousness of their condition, where they may just be completely bedbound or unable to eat, or things like seems to, alongside a lack of a lack of proven treatments for them, does seem to provoke sort of panic or distrust or anger sometimes amongst health professionals, that can lead to a sort of disbelief or to inappropriate interventions or safeguarding reviews or even mental health sectioning, which is sadly not nearly as uncommon as one would hope. So I'm not going to ask you why that happens, but I'm just going to I just wonder instead, if we think back to perhaps the early days of the AIDS pandemic, I wonder if you see any parallels in terms of people, relating to that disease when it wasn't known, when it wasn't understood, and how people and how perhaps doctors, responded to patients.
Yeah, I think there are lots of parallels. As you say, we didn't have that research knowledge, and patients had to really fight for that research to be done. And, I state in the book that ACT UP, which was the big activist group, still is a big activist group, which really pushed for research into treatment. Their logo is silence equals death. So if they had stayed silent, they would have died. We wouldn't have the treatment that we have nowadays. So I think there are parallels. I think, I think HIV/AIDS affected people who weren't listened to anyway. So these were often quite stigmatized groups. And I read a very interesting book by a sociologist who talked about one of the good things about HIV/AIDS is that it did affect a lot of well-educated, well-connected white men in the global north, most of them who were gay, but they were holding down jobs where they were well-connected and they had certain social capital, and because of that they were able to get into spaces and really start to get the message out there. And I think that was one thing to their advantage. It changed HIV for everyone else. But I think at the time, certainly physicians and researchers were scared because they didn't know what caused HIV. We didn't know it was HIV. They didn't know what caused AIDS. And in that kind of, not knowing and then also I think there's a thing about being challenged. I think doctors can get very defensive when they're challenged. So, why don't you know? What are you going to do to make sure you know? All these things. I think that's probably has meant that certainly, in the past and now, that defences are put up. And yeah, I can see those parallels, absolutely.
Absolutely. And I think, it can be, in some situations, something of a red flag to some healthcare professionals when patients come in well educated on their condition. Because I know you write in your book, the importance of, try to learn something. Try to come in. Many doctors will appreciate the fact that you've tried to, educate yourself to a degree. But of course, it will be the case with some conditions that then, doctors may feel that their hierarchy, their position of hierarchy in that knowledge with respect to that condition is being usurped. So that's another danger point, isn't it?
Yeah, and I think that's why I call for more humility in listening and understanding. Someone who's living with a condition may have way more. I mean, not only lived experience, learned experience. Have done way more reading on their condition than you will ever know. So trying to listen to that, being willing to read research, I think all these things are really important. So recognizing that we're not always the expert on, well, certainly we're not the expert on other people's bodies, but we're not always the expert on conditions either. We may still have a lot to learn. So that we need to be more humble and more open to listening, to learn more.
Thank you. And yeah, I'll just do a quick shout out to or say to any doctor to have a quick visit to the Science for ME pages if they really want to see, extraordinary level and depth of conversation and around medical knowledge and lived experience combined together, that exists out there. Thank you thanks for coming with us, down that alley, because it's just in that it's that crossover between the bits where your expertise is greatest and the lived experience of our audiences, because I understand that's not easy to explore, but it's some very valuable insights. Thank you. Shall I move on to a sort of a curveball, as it were? I know everyone talks about AI these days, but this is one of the situations in which I think it might be getting quite interesting. Do you think the adoption of AI will impact medicine in the context of silencing and chronic illness? So some with ME and long COVID find AI more knowledgeable, more accurate, and more impartial than some of the doctors that they've encountered. Do you think there's potential for it to support them or their diagnosis or their care? Or do you think there's a danger that it might, they might be shunted off and it might actually contribute to their further silencing in the long run?
So thank you for this question, because it's really made me think about things I have never thought about before. So I appreciate that. So I have to say, when I thought about AI, I think a lot about AI reading scans in a way that's quicker than humans. I think about AI doing the jobs for us, that, writing down our consultation notes so that we don't have to. I think that's often the way that doctors think about the future of AI. It's doing those tasks that would take much longer for us to do. But obviously I do know that AI is looking at consultations, and I think it's really fascinating to hear that people may feel that AI is better than human doctors, and I think that says a lot about us as a medical profession. Yeah, and of course AI has the ability to get all that information that a human being may not be able to read, so they may have more knowledge. Absolutely. So I think there is a case for it there. I'll be very interested to see what people's reactions are. I think it would suit some people, it wouldn't suit other people, like most things. And I think not my only one, but a note of caution would be that obviously AI is built by humans. There'll be doctors in the making of it, and we have to be really careful about bias. And we know that AI holds bias just like everything else in society, just as we do as human beings as well. So I think I would look carefully to see how it's being rolled out, and I would love to hear more how people find it. What's your opinion on it, Rupert?
Oh goodness! Now you put me on the no, put me on the spot. I think the last point you make there about AI is controlled and made by humans, but also that, and of course that it reflects all the biases that society currently holds within medicine and in wider society may or can be reflected in it in multiple ways. But I mean, I have to say, from just the personal experience of people around me, in there, just as they start to reach out and just sort of experiment with AI, as I do, starting very tentatively to do as an academic, but people around me with chronic conditions are saying they're actually able to, instruct it to so that it asks useful and pertinent questions based on data and research, to check in and and check on their sort of level of health, or whether there's anything of potential concern, or others are even saying to with a massive lack in access to support services like mental health support services, just asking it to act as in the role explicitly as of a counsellor, not to provide any sort of cure, but just to help them reflect back on their mental state, and so as to better manage it when they're dealing with chronic health conditions. So yeah, I have no profound insight, but I'm just really intrigued. My antennae are twitching because I'm hearing some quite interesting things about it.
Yeah, thank you for sharing those. As I said, it's a viewpoint that I haven't heard before, so I think let's watch this space and see what happens. I think my real push in the book is to really challenge power hierarchies in medicine and in health research. I think this issue of listening at different levels is really important for patient safety and for health equality. But I think there is massive power imbalances in medicine that need to be challenged. That's my what I hope this book will achieve. So let's see.
Lovely. Thank you so much for your time. Honestly, it's been a genuine pleasure. And one more just shout out to our audience to please go. There's so much more in the book in terms of powerful stories and fascinating insights, as well as just to appreciate the depth, complexity, and spirit of your writing. So thanks so much again, and it's been such a pleasure to have you with us.
Oh, thank you so much.
Thank
I've
you for
really
listening to our Pedantic Zebra
with you, and I'm also massively grateful that you guys have chosen my book to read and talk about. Thank you. Good night.